Cleo. Okay. Well, I'm delighted to introduce this morning's Grand Round speaker, Robert Michel, who is a name that I think everybody in this room is very familiar with. Robert is known for many things in the laboratory industry, but especially for the DARK report, which he created in 1995 and has been the editor-in-chief of that since its creation. The DARK report, of course, is an intelligence service and a publication dealing with economic and strategic assessment of the clinical laboratory industry, and is aimed really at senior executives and pathologists, but is very widely read. He also produces the Executive War College on clinical laboratory management each year, which is a widely attended meeting which is attended by leaders in the industry throughout the United States and internationally. Recently started a website, the DARK Daily, and his briefs are read by more than 20,000 people in 186 different countries. He has, in the last several years, traveled to at least 15 different countries for laboratory conferences of various types as a speaker, and he's visited laboratories in many countries and essentially all of the continents, with the possible exception of Antarctica. And had you been here last week instead of this, you would have thought you were in Antarctica.
Getting out today before tomorrow's snowstorm, right?
Robert is the winner of the Newsletter and Electronic Publishers Association prestigious Best Investigating Reporting Award, and is listed in Who's Who in Healthcare and Medicine. I first met Robert a couple of years ago on one of his international speaking engagements at the Egyptian Society for Clinical Pathology meeting, which was sandwiched between two revolutions. Actually, it wasn't quite out of the first one, and it turns out we are both negatively affected in our air flights out of Egypt. We got to spend a little extra time, and we had a delightful time together touring a bit in the shadows of the pyramids, and so it's a special pleasure, Robert, to have you as our guest and speaker today on why healthcare's evolution creates new roles for clinical laboratories.
Thank you very much. Good morning. Since I live in Texas, I can say y'all. But do you know what the plural of y'all is?
All y'all.
All y'all. Good morning, all y'all.
I trained in North Carolina.
Okay, so a good way to understand what I've been doing, I'm an old Procter & Gamble fellow who found myself hired at Nichols Institute back about 1991 when Al Nichols was running it. It was a publicly traded company, about 300 million in size. And some of you who go back a ways remember that MedPath, then Corning Clinical Labs, now Quest, acquired Nichols Institute. And about that time I was living in Portland, Oregon, and the thought of moving to Teterboro, New Jersey wasn't high on my list. So that was the genesis for creating the DARK report. And I think a simple way for you to understand this is you as physicians in laboratory science are great with medicine, but have much to learn about money and management and marketing. And so that's the gap that I've been filling over the last 20 years. And so what I want to share with you today, you're in an academic environment, you're increasingly engaging within the community, and I wanted to take you outside lab medicine for a bit and really talk to you about what's changing in healthcare that's going to directly impact what you do as laboratory professionals. So the idea here is to take you up to the 40,000 foot level and let you understand some of the macro trends that are driving what's happening in healthcare. And we can say definitely that we're undergoing an evolution. And this evolution is going to create new opportunities for laboratories. So I've got 5 basic areas of healthcare change that I'd like to share with you. The first one is who pays for healthcare and what's going on with this. And I'm going to give you an idea of why the money pot is rather empty. And then the second thing is reimbursement. Independently of who's paying for healthcare, increasingly we're going to see new models of payment. And in particular, this is going to be problematic for labs because fee-for-service medicine is on its way out. Rick and I have a friend in the lab business, Leo Serrano, who's now down at Broward County, 4-hospital public health system. He told me that his hospital now gets 90% of its revenue from non-fee-for-service sources. So this is how quickly in certain markets the fee-for-service shift is happening. And then we have the end of the private practice model that's been common for physicians who are practicing in office-based settings. Number 4, you all are right on this curve, which is a change from reactive medicine to proactive and personalized or precision medicine that's informed by genetics and molecular diagnostics. And then the last one I want to talk to you about is quality management systems and what's happening in this field. It's something that hospitals in particular are going to need to pay greater attention to meet quality demands of both consumers and those who pay for healthcare. So we're going to get into number 1, but I want to put up about 3 slides just to remind you. I'm not going to talk about each one of these bullets, but just to remind you that these kinds of trends are still active. So the move away from reactive and towards proactive care, different demographics. We know the incidence of chronic disease and the aging baby boomers are going to drive things. Personalized medicine. In Medicare, these are 6 different initiatives unfolding within Medicare over the last 24 to 36 months. ICD-10 is in your world here in another 5 or 6 months. And then in the private payer side, you have similar things being implemented in a slightly different time curve. So then let's look at the money. And I don't think many of you realize that in our $2.4, $2.8 trillion healthcare spend, the federal government actually pays for more than half of that now. And the reason they pay for more than half of that goes beyond Medicare and their share of state Medicaid programs. It's the Veterans Administration, 7-8 million people in VA care, plus the active duty military, plus the beneficiaries in TRICARE, and then there's several million federal employees and their dependents that are covered. So healthcare costs are a big deal at the federal government. So let me tell you why the federal government's in a real squeeze. I'm going to show you 3 or 4 slides that you never see in the New York Times, the newspapers, or in the media, but it'll give you a framework for why you've had such a rancorous debate in Washington over the last few years. What this chart shows you is spending and revenues as a percentage of gross domestic product from 1960 to projected 2020. And this blue line here is federal revenue as a percent of GDP. It's averaged 18%. And this red line is federal expenditures as a percent of GDP. Now, there's some interesting things that you can see here. This is about 20%. We have a surplus here right about 1998. Does anybody know who was president when we had a surplus?
Clinton.
Bill Clinton. And who was Speaker of the House? That fellow, Newt Gingrich, right? We had a surplus, and I can remember reading in the newspaper that the federal surplus was so large that if the federal government invested it in equity stocks, within 2 years they would own all the stocks that were being traded on the New York Stock Exchange. So when we elected a new president, for better or for worse, there was a Democratic Senate and a Republican House. This is when the Bush tax cuts were voted in, because they had more money than they could spend. Now, of course, that administration was not as frugal in its spending as the previous one, but here's 2008. You remember the mortgage bailout, and you remember the bank bailout, and then we started a recession at the same time, didn't we? Look what happened to revenues as a percent of GDP because of the recession. And this is that $4 trillion deficit gap the first couple years. And then some of you remember the 2010 election, let's see, that's the red line. Remember there were certain Republicans say, well, why don't we take spending back to the 2008 baseline? So the new administration has really tried to bake in a much higher spend of federal revenue or federal expenditures to GDP than we have seen in historical years. And this is the gap that they have to make up. And you can see historically they've not been able to tax enough money to make up that gap. And I'm going to show you this slide, which goes back to 1929, so that you can see again, average receipts are 15% and average spending is 18% over this time period. Here's World War II. We spent a lot of money to beat the bad guys. And then here you go, there's that little surplus period, and then we get back into the recession, and you can see the effects of that. Now, what does all this mean for healthcare? Well, the next slide is going to help you understand why the federal government's in handcuffs about putting more funding into medical education, into Medicare and Medicaid. If we start with 1980 here, this is the federal debt as a percentage of GDP, and we had a $1.7 trillion debt. If you advance to 2008, right before the bailout of the banks and the mortgage companies, we had just under a $10 trillion debt. Now, I looked this up yesterday, and currently our debt is 17.655 trillion. Okay? Now, why is this significant? You remember the pigs in Europe? Some of you who are good on your economics? That was Portugal, Ireland, Greece, and Spain. And it was a big problem for the Eurozone because they didn't have enough revenue to pay their national debt. So here's what those percentages were. Portugal was 123% debt to GDP, Ireland 118%. You've got Greece at 156. This is why this was particularly painful for Greece. Spain was 84%. Any idea what the debt to GDP is for the United States these days?
About 77%.
77%. Any other guesses? Watch this. 104%. So we're not far from the same debt to GDP that the big countries were. Now, why is that working for us and it didn't work for them? Because the world will buy federal bonds. The world won't buy bonds from Great Britain and Greece and Ireland when the economies are not doing well. Okay? Now, here's what I want to show you. Let's see, I have to skip a slide? No. At the state level, states have the same problem. This is a chart from the New York Times in 2011, and what it's showing is the dark green are states that fall short of having 80% of their state employee pensions funded. Blue are states that exceed the 80%. Now, many of you have seen the headlines about Illinois. Illinois' state pension trust is expected to absolutely go broke, $0 by 2017, subject to any reforms that they are trying to pass right now. And in order to fund the state pensions, it would take 30% of the state revenue from 2017 on to maintain pensions. Ohio has a big number here, New Jersey. Now, the blue ones, I live in Texas, we've got a 6.4 trillion or billion surplus. California's in good shape, Washington, Oregon. This gives you an idea of how many states are strapped for funding and don't have the ability to put more money into Medicare and healthcare services. Okay, I thought I'd give you a quick look at how much per capita spending is for healthcare by states. Does anybody have an idea which state is the most expensive state for healthcare?
Probably Alaska.
Massachusetts. Now that's a good one because actually you start with the District of Columbia, which is about $10,400 per person. But Massachusetts is next on the list, $9,278 per capita. Any idea who's the least expensive? It's those clean living Mormons in Utah, $5,031 per person per year. And Arizona, $5,423. So the darker blue are the more expensive states, the lighter blue are the least cost states. So you can see there's a lot of variability in what healthcare costs. Now, a comment on Massachusetts. I was with John Gilbertson, who's the pathologist informatist at Harvard Mass General, a couple of months ago, and I said, you know, I can't read much in the newspaper about what's happening with mass health. You know, is it working? Is it not working? Tell me what the reality is, because you're there and you're in healthcare. And you know what he said? He said, primary care access is so bad now, you have to have a friend who knows a doctor in order to get an appointment in primary care. He said, that's the reality. Okay, so I want to sum up. Who pays for health care? Well, the federal government's paying for half of it. Employers pay for a lot of the balance. And I want to show you a really interesting dynamic to our economy that no one talks about. You've got the federal budget, and this is why they battle all the time. There's no short-term solution. I suggest that as providers, you're going to see more cuts. But here's the big thing. If you've got a $17 trillion national debt, what are interest rates currently? 1 to 2%? Right? So if you have a $17 trillion debt, you're paying $170 billion in interest, right? What would happen if interest rates went back up towards 5%? Look what happens. The federal government's got to pay $850 billion. Now, there's a takeaway for this. The system, and this is everybody in the system, both parties, they're stealing from your parents and your grandparents and yourselves. Because throughout the 20th century, you could get a positive return on interest rates and build your retirement. So everybody in this room, your pension plans are not appreciating like they should, because you now understand why the federal government has artificially suppressed interest rates, hasn't it? And you can see what will happen to the funding game if they had to pay 4, 5, 6% interest. My mother, bless her soul, in the 80s, 1990s rather, she died at 88. She had a $100,000 CD. In those days, it would bring her in $6,000, $7,000 per year at 6 to 7% interest. My same grandmother, my mother today, would be getting $1,000 in her retirement. So this is a big deal. And I want you to understand, this is why the federal government has handcuffs and why the Democrats and the Republicans are fighting bitterly over what to do. Okay, so let's shift gears. You understand then demand for spending in all categories, education, defense, highways, and healthcare, they're all competing. We also know that the demographics say that these will be budget busters if they don't reform them. And states have their own budget crisis. So this is the one takeaway I want you to understand. There's no money in the system, okay? Employers who fund benefits have their own issues. So, number 2, new reimbursement models. You're going to see some interesting things come down the pike in the next 5 to 6 years. This isn't going to happen overnight. It's not like your fee-for-service billings today are going to be entirely different in 24, 36 months. But what you should understand is that we are moving to what they like to call value-based reimbursement as a global term. You'll see bundled payments. You're going to see capitation, or per member per month. This will include both AP and CP testing, and some kind of pay-for-performance models. And both Medicare and private payers have accountable care organizations right now that are in the first iterations of trying to work out how you pay a set fee to the ACO and how the ACO divides that between the hospitals, the physicians, and the ancillary service providers. So now, for lab medicine, here's our problem. Some of the graybeards in this room remember DRGs in 1983. And that was the death of clinical pathology professional, wasn't it? Because many pathologists made the rational decision to focus on surgical pathology and let clinical pathology go down the ways because the government wasn't going to pay for it. If we put a bundled payment into ambulatory care, which providers get how much of the pie? Including lab, radiology, physical therapy. So this is a big challenge for the industry. The College of American Pathologists, the American Society for Clinical Pathology, they're deep into trying to figure out how to educate the policymakers that lab medicine should get its fair share. Okay, 3 rules, 3 slides. The July issuance of the draft Medicare physician fee update for 2014 had 3 rules that in their draft form would have been very financially destructive to lab medicine. And they walked back some of the worst of this when they published the final rules in November, early December, and they took effect January 1st. So this one is the clinical lab fee schedule. Starting in 2014, this should be 1,225 tests. Over the next 5 years, they're going to take 250 tests. They're going to look at them to see what has changed since the fee was established in 1984 or since. And based on technology, they're going to change those fees. And this is a statutory authority that CMS has never used. We expect that they'll take the 250 highest volume tests. Remember Pareto's law? 20% of the population has 80% of the impact. So you can expect in 2015, 2016, things like routine chemistry and hematology are going to be much differently priced by Medicare. And that's going to be a big problem for Quest and LabCorp in particular. So this is the first rule that CMS is implementing this year. The second one is the physician fee schedule. Those of you who are pathologists know there was a proposal to cap the payment rates at the same level as the hospital outpatient prospective payment system. And the ASCP said 38 of the 39 pathology services would be reimbursed at rates that were less than cost. This was a very aggressive grab by CMS, which they were forced to walk back. So this didn't happen this year, but it's in the queue. I talk to people who lobby for you in Washington, D.C. They tell me every potential cut is on the list and comes back every year, which is why, once again, the graybeards know about the 20% Medicare copay. It's always on the list because Congress has to figure out a way to offset spending here in order to spend there. So this won't go away. And then the last one, the hospital outpatient prospective payment system. They want to reimburse for hospital outpatient and freestanding ambulatory surgery centers at a bundled fee. So some of the fee for service that's gone to clinical lab and AP is going to have to be in the bundle. We are just now starting to get into the actual filing of claims for these procedures, and CMS is starting to create complicated regulations on when a test should be in the OPPS bucket and when it shouldn't. So this is something that's going to reduce income to labs over this calendar year and going forward. Okay, the third piece of this. In the academic settings, this affects you less than it does the community hospital laboratory outreach and also the Quest and the LabCorps and the Sonics around the U.S. The physician market has traditionally been where most independent labs get their specimen referrals. Office-based physicians have traditionally been owners of their own medical groups, haven't they? They're either private practice partners or they're shareholders in the professional corporation. So I'm going to show you some things that are happening and have already occurred that really change the dynamics and are problematic for Quest and LabCorp. New practice models evolving. The physicians are no longer self-employed. And then Gen X and Gen Y, hello to all you Gen Yers in the room, you have a whole different attitude about being an employee versus an owner partner in a medical practice than the baby boomers did. So there's some demographic elements that reinforce this market transformation. So I would suggest to you that we are seeing the end of the private practice model of medicine. Marcus Welby notwithstanding, in the last 8 years, the transformation of most medical groups from a doctor-owned to an employee model has been substantial. Now, what happens is, who's buying these groups? Mostly hospitals and healthcare systems and some insurance companies. So now you have employees, employers are also operating corporate clinics. The new owners are going to make a decision on who should be their lab provider differently than a private practice physician who's looking at a variety of factors, including in a client bill state, whether Quest and LabCorp will give him a deeply discounted price that he can mark up to Blue Cross. Okay, so I want to show you how rapidly this transformation has happened. This is data from the Medical Group Management Association. It's the year 2002 to 2008. So this is just 6 years. of the last decade. We started with 70% physician ownership, and by 2008 that was below 50%. That's the red line. The blue line is hospital owned. Started at 20%, finished over 50%. Now that transformation happened in 6 years. And then this chart is also from MGMA. It brings it forward from 2008 to 2011, and you can see hospital ownership now is 60-65%, and docs are moving down to 30-25%. So this is a trend that's already passed, and it'll be very small groups, 1, 2, 3 doctor groups that probably haven't sold. Then this chart reinforces what I just showed you. This comes from the American Medical Association and Accenture, and what you're seeing is this is the number of docs 2000 to 2013. This is 700,000, so you see we're over 700,000 docs now. And then the line is the percent of independent docs. And you can see that it's been declining. Even as the number of physicians in practice has increased, the number of physicians who own their own medical group has decreased. So this is an impactive trend for independent clinical labs, because it means they have to go sell a different kind of buyer than they've had to in the last 30 years. Okay, this is a big deal for all of you because you're part of a hospital and a health system. And this is particularly troublesome for community hospitals as opposed to academic centers and some of the larger health systems. If you're trying to keep people out of hospitals, then the largest source of patient business is going to be outpatient and outreach, not inpatient. And this is already happening. Let me show you. This is MedPAC data for 2004 to 2010, and what it's doing, it's showing Medicare inpatient and outpatient services on a cumulative percent basis. So this line right here is the cumulative percent change in that 6-year period in inpatient services, and it declined a cumulative 5%. And you look at the top line, that's a 30% increase in outpatient services for Medicare beneficiaries. So this is another trend that's already well underway, and it means that hospital outreach labs need to be much more nimble on how they reach those patients that are increasingly being served in an outpatient setting as opposed to an inpatient setting. You know, Leo, we talked a little about this during the Priscilla Cherry retreat, about that need to bring community and academic together. Okay, here's a quote. Wayne Smith is the CEO of Community Hospital Corp, which runs a number of basically small community hospitals for profit around the United States. He says, healthcare is improving greatly. We're admitting people who truly need to be admitted. Okay? And then SG2 is a Chicago-based consultancy. They project a 17% growth in outpatient services going forward, where hospitals already generate more than half their revenue. So you have a change in the setting of where care is provided. And I borrowed this slide from Jim Crawford, who many of you know is the chair of pathology at North Shore Jewish Long Island. Dr. Crawford also happens to be chairing the Medical Homes Business Model Development Task Force at North Shore. And this was published in a peer-reviewed journal in 2010. And the premise of a medical home is let's keep people out of the hospital, let's keep them healthy. So look at what you see. The first one, Group Health Cooperative up in Seattle. Their medical home patients had 16% decrease in hospital admissions. Geisinger Health, 18% decrease. VA Midwest, which is Milwaukee and Chicago, 27% decrease. Health Partners is your Mass General, 24% decrease, and Intermountain Healthcare, 25% decrease. Now this is before 2010, isn't it? These are the models, these institutions were used to model ACOs, if you connect the dots. So you can see that if you change your care pathways, you can succeed in keeping people out of hospitals. So guess what? I was talking to a lab administrator on Long Island in April, and she says, you know, our inpatient counts are dropping. We've called other community hospitals on Long Island. They're telling us the same thing. And I got on the web while she was on the phone, and I found this little blog. So this is 2006 to 2011, change in inpatient use rates per 1,000 population. It's ranked, these are the 14 states that had the most impact. And guess who's number one? Minnesota. Inpatient counts down 14% during that period. And then I thought it interesting that California, with almost 40 million people, is down 7%. So this is clearly a trend, proactive care, that's engaging. And then if you look at this thing about ACOs, I'm putting this up just to show you how fast ACOs have grabbed. This company says between 37 and 43 million people, 14% of the population, are already in ACOs. That's Oliver Wyman. And I have the fellow from Oliver Wyman coming to speak at the Executive War College in April. So, this is a great slide. I just found this. Frost & Sullivan is a financial analysis company. They're showing how the healthcare dollars are now going into different spending buckets. So the way to understand this slide, your light blue, this is the amount of money spent on prevention. Darker blue is diagnosis. That's our sweet spot, isn't it? And the top dark blue here is monitoring, and then this is actual treatment care. And the first one is 2007, this is 2012, this is 2025. Now look what's happened. In the 5-year period, prevention has gone from 5 to 7% and will almost double to 12%. The diagnosis has gone from 15% to 17%, and it'll go to 21%. And then up here, monitoring has gone from 10 to 12, and it'll go to 16%. Now, isn't lab medicine used in prevention, diagnosis, and monitoring? You're the place where all the action's going to happen. The docs need your information to get better outcomes from patients. And then look what happens to this middle bucket, which is treatment. That's what acute care hospitals do. It shrinks 70 to 66% to 51%. Okay? So this is an important slide because it's showing you that just over the last 5 or 6 years, this transition in where the money gets spent is already happening. Okay, number 4. We're going to talk a little about the personalized proactive medicine. This is going to play to your sweet spot because you all are right on the front curve of molecular diagnostics and genetic testing. Okay, your entire career, except the newbies here in the room, reactive medicine. Nobody cared about Robert until he felt bad and showed up at the doctor's office or the emergency room, right? I could disappear off the system for a decade if I was healthy. The new model is that I'll be in a medical home or I'll be in an ACO, and particularly at my age, there's going to be a nurse calling me saying it's time for your colorectal screen, your cholesterol's too high, your weight's out of line. I've got a Humana HSA policy. In the last 5 years, I'm regularly getting emails from Humana and auto phone calls at the house offering me opportunities for stop smoking, lose weight programs. This has never happened in earlier decades. The emphasis now is keep Robert out of the hospital. Keep Robert from going acute. So, coming soon to a provider near you, proactive medicine, let's keep them out of the hospital, personalized, which I like the term precision, informed by molecular diagnostics, and then genetic analysis with whole human genome sequencing. We're going to talk a little about that. Okay, so these are new paradigms for healthcare. There are many people who've been out in healthcare 10, 20, 30, 40 years. This is a change in how the system wants them to practice medicine. Keep patients out of hospitals. You saw the data. That's already happening, isn't it? Okay? University of Minnesota can have a growing inpatient count from one year to the next. 3%, 5%. But guess what? The outreach is growing 8 and 10 and 12%. The business is shifting. So, you want to detect disease early. It's easier to treat. You want to manage chronic disease. And you want to use incentives to encourage positive lifestyle choices. So you're going to see more and more employers put out incentives for you to join a non-smoking program as a covered beneficiary, to lose weight, get exercise, lower cholesterol. This is happening in the Fortune 1000 world at a very speedy rate. Okay, Age of genetics. Now I'm going to test your knowledge of history. Okay, what age of man does this picture describe? Come on, gang. You remember your 8th grade history. The agricultural age, right? And it ended about 1780. What happened then? They invented those spinning mills in England. You didn't spin wool in the cottage, you went to work. And the Luddites didn't like that, do they? They were like today's unions. They were very objected to the status, to changing the status quo. So the next one. What was the next age? Right. Do you remember who this fellow was? Henry Ford. Very good. Oops, I'm sorry. There he is, Henry Ford. What did Henry Ford own? He owned a car manufacturing plant. He owned iron ore facilities, steel mills, trains. He owned real things, okay? So this is the 20th century, the industrial age. So what's the next stage that followed the industrial age? Any guesses? The information age. Who's this fellow? And he was the world's richest man for a long time, wasn't he? Now, what did the world's richest man actually own compared to Henry Ford? Do you see, this is how you can watch society change from one age to the next. Because Henry Ford was wealthy about the physical things he owned. Bill Gates was wealthy because he controlled knowledge in the information age. Okay?
Although to be fair, what made Ford wealthy was his methods, his processes.
But you measured his wealth in material things.
This is true.
That's the key thing. You're right about Henry Ford, who inspired Taiichi Ohno at Toyota. Okay, so what age do we open the door to right now? Genetic age. I would assert to you we're at the front end of man's genetic age. Anybody recognize this gentleman? No. Go back to the 50s, please. That's it.
Oh, he looks so different.
Well, this is a more recent picture of him.
This is called the old age. No?
Yeah, right. He's a graybeard. Okay, now, who's this fella? Here's your hint. He's a surfer scientist.
Kary Mullis.
Kary Mullis, very good. And what did Kary Mullis do?
Invented PCR.
Bingo. Okay, and look, Nobel Prize. Nobel Prize. Now, I'll tell you a little Roche LabCorp story. Back in the 80s, there was a fellow named Thomas McMahon who was on the Roche Global Executive Committee. Thomas McMahon said Roche ought to spend several $100 million, when that was a huge amount of money, to buy the PCR patents from Kary Mullis' employer. That was a career bet, because if it hadn't gone that way, Tom McMahon would have been gone from Roche. But it worked out pretty well, those of you who have paid Roche patents for PCR. That's one of the reasons then when National Health Labs and Roche Biomedical Labs was created in 1994 as LabCorp, that Thomas McMahon was the CEO there from 94 through his retirement about 2005. Okay. You all have the opportunity to be change agents. And in an academic setting, you're very well placed to be on this front curve of helping physicians get better outcomes and shift the cost per episode of care. So think about the HER2/neu test and the Herceptin, that kind of thing. I would suggest to you that we are all living in a time that 50 and 100 years from now will be in those 8th grade textbooks. It was the start of the genetic medicine, the genetic age. Everything you're doing now is the first time we've cracked open the DNA and looked at what it does, what functions it performs, and then how to play with it. And in fact, I'm tracking regularly scientific efforts where they're creating living computers, or computers out of living cells, and they figured out how to do the binary ons and offs. So you're going to find that we're probably going to be in a very organic, non-metallic world in 10 or 15 years. It's all based around computing, but it's using organic structures. So, big deal. You guys all get to lead in this field, and molecular and genetic testing is going to be great value as we learn more about it. Now, you all know the exome? I put this slide up for the audiences that really don't understand the exome, because essentially that's the 1% of the 3 billion base pairs where the genes reside and the work gets done. However, there's a lot of research going on in the dark matter, or junk DNA, and they're beginning to realize that junk DNA is doing a lot more than anybody ever imagined. So here's an observation. Places like, I know that Sick Children's Hospital in Toronto, I heard one of their geneticists speak there in November. They have the Life Technologies Ion Torrent. They can do an exome now for $875 in about 4 or 5 hours. However, the exome won't be enough as we crack what's going on in dark matter. Okay, you all know about companion diagnostics, right? That's the diagnostic test that's matched with a therapeutic drug. Increasingly, the FDA will only clear a drug for clinical use if there is a companion diagnostic that predicts that the patient will get therapeutic value. And this list just gives you an idea of some of the FDA-cleared tests, therapies with diagnostics, and then who they are. So this is a growing field. And my prediction is that the pharmaceutical companies have large numbers of compounds on the shelf from the last 60 years where they know it's therapeutic for 5 people out of 100, but that was never enough to get FDA clearance. And at some point they're going to wise up and say, hey, can we find the right biomarker and we can bring this drug to market and safely use it with clinical value. Okay, here's a big deal on gene sequencing. You're one of the first to hear my interpretation of this. Illumina just got the FDA to clear its latest generation whole human genome sequencing instrument and reagents. Then I noticed within weeks, Quest issued a press release. It was buying this and was going to set up and offer this in clinical purposes, and LabCorp is doing the same thing. And Illumina says that in volume, you have to run a lot of these, because I think the machine's $10 million. You can do a whole human genome sequence for $1,000. So we're getting very close to that benchmark that you've been hearing about for the last decade. Now, MALDI-TOF. I wanted to put this on your radar screen. Everywhere I'm traveling, and in Europe, mass spec is being developed to replace a large number of traditional clinical assays. Set aside for a moment the more precise analytical measurement of mass spec versus an immunoassay. You get rid of reagents and test kits. And if you have a fully automated mass spec instrument, then you reduce your complexity of labor problem. So you're going to see a lot of MALDI-TOF hitting the market. I'm giving you these examples. bioMérieux had Vitek, which is their load and walk away mass spec instrument. I saw this at MD Anderson last year. It was in their microbiology lab. MD Anderson in Houston does only cancer patients, so compromised immune system's a big deal for them. They told me they have to manually load the little cassettes, but once they put them in the load and walk away mass spec, they get an answer in 30 seconds. And time to answer is important at a place like MD Anderson. And then Bruker got their MALDI-TOF load and walk away approved. And Bruker was used by Quest for their vitamin D testing over the last 4 or 5 years. So Bruker had a motive to automate the manual mass spec to the benefit of that large customer. Next up, QMS, Quality Management Systems. This is an important thing for you all because you may be familiar with ISO 9001. That's a QMS that's accepted around the world in manufacturing, distribution, service businesses. For the last 20 some odd years, companies have wanted to certify to ISO 9001. It shows that as a supplier, it has acceptable quality. Around 2003, ISO 15189 was issued for medical laboratories, and you accredit. Now in the ISO scheme, a company can certify by having a third party come in and say they're working to it, or they can even self-declare. For accreditation, the assessors will come in and make sure that the quality management system is used in all functional areas of the organization, which includes sales, finance, administration, customer service, inventory management, as well as testing. But then the assessors also will assess the testing done by the laboratory to assure that it's accurate. So accreditation is a bit more intense than certification. CLSI has their QMS GP38, and for those of you who've been doing Lean Six Sigma, this is the next, let's say, evolution of where quality management goes. Because a QMS is based on gathering real-time data, looking for systemic sources of errors, reducing variation in workflow, so that you increasingly can approach a Six Sigma performance, which is less than 2.7 errors per million events. Now, what is the value? This is important. The value is that you're getting everyone across the organization understanding what happens systemically to each workflow process. And it's based on real-time collection of data. It supports this continuous improvement and a system of prevention. How do you design your lab where nothing can go wrong with the specimen? It can't get lost, it can't get mishandled, it arrives at the bench in perfect quality. Well, this is how a QMS can help you do that. It also, as a QMS, allows your customers, physicians, payers like health insurance companies, the patients, and the employers to understand the quality basis of what your lab does. And I've got a couple of slides to talk to you about how Dr. Westgard's looking at this. Big deal. This is Det Norske Veritas. In 2008, CMS gave D&V, a Norwegian firm, deeming authority to accredit hospitals to Medicare conditions of participation. First accrediting body since Medicare was launched in 1966. What D&V does is not only help the hospital meet its COP with Medicare, but also achieve an ISO 9001 certification. And as a result of that, some of you may have noticed, the Joint Commission has gotten more active about putting in Lean and Six Sigma and process improvement services. So this is CMS at a higher level, starting to encourage the adoption of quality management systems. By the way, ISO 9001 is used in 80 different countries. ISO 15189 rather, is used in 80 different countries as their national license or accreditation standard. In the EU, blood banks had to be ISO 15189 accredited, I think by 2010. And Britain is just beginning to move all its laboratories onto this. So it's a world accreditation program. Now, I wanted to show you a few slides that I borrowed from the good Dr. Westgard. We talked about this at dinner last night. He's really getting in, he's been influenced by W. Edwards Deming and Taiichi Ono. And he's really starting to get into now, how do you know your QAQC is accurately measuring what you do? You may be getting the same results, but are those the right results? And I just wanted to show you this slide. This is his way of presenting what would be a Six Sigma performance. And so he's got some new tools that would show that every time you ran a CBC or a thyroid test, your ability to reproduce that accurately falls in either this level or by sigmas moving to world class. So this shows you how Dr. Westgard's thinking and his tool sets are evolving consistent with system of prevention, better measurement, and better confidence in what you're measuring. And I put up these two slides just to show you that within the QAQC program of a lab, this is a client of theirs, they were able to save 45% in reagent supplies and 45% in control materials. And then I thought this was interesting, not just savings from running QC, but 40% fewer QC failures to investigate with a higher level of confidence that your QAQC program was dialed in. So this shows you how the QMS system of prevention philosophy is beginning to filter into lab medicine through some different areas. Okay, I'm going to close up here and we'll have time for some questions. Big deal now is you as a laboratory want to think about how you add value to the physicians who are ordering your tests and the patients who are getting the results and the payers like the health insurance companies that are funding this. And I want to put up two examples from John T. Mather Hospital in Long Island, 248 beds. So the lab's doing 2.3 million tests. Medicare no longer pays for hospital-acquired infections, right? So we're doing more testing as people come in the front door to figure out, are they bringing the bug in? So at Mather, Denise Geiger, PhD, is the administrative director of the labs there. She worked with the medical team at Mather, and they targeted MRSA first. 2007 was their base year, 74 infections. She proposed that they move to a rapid molecular diagnostic assay. And over the next 5 years, this was the screening cost, no additional FTEs in the lab. MRSA was available 24/7, I think with a 4-hour time to answer. And look what they did in driving the number of infections from 74 down to 18 in 2012, 13 in 2011. So there's where they hit the bottom. Now, if you look at the costs that were avoided, it totaled 1.96 million, net out the 448, and there was about 1.5 million in savings to the hospital. Now, if you were a patient, would you like to know this public data before you selected a hospital? Certainly. So then they said, this works so well, let's do it for C. diff. And so for C. diff, they decided to keep the immunoassay, but only triage a certain portion based on the immunoassay results into a rapid PCR at $40 per test. This shows you the volumes. These were the additional costs, so $86,000. Again, no other FTEs in the lab and 24/7 coverage on the test with a 4-hour turnaround. And you see that in this program, they started with a base of 70 and drove that down to 26. And then the savings that they ended up with was a net of about $1.5 million. Now, if you're a laboratory, is this a big win for you in the hospital? So this is a roadmap. It's the kind of thing that you all know how to do and know how to do well, but it requires more engagement outside the lab with strategy. I'm going to tell you a quick little story. This is about 4 or 5 years ago. I picked up a press release. I believe it was P&A Fish for blood infections. And the headline was, hospital mortality drops 54%, morbidity drops 74%. And it was Washington Hospital in Washington, D.C., MedStar Hospital. So we called up the test manufacturer, and they introduced us to the pathologist, and we did an interview. This is really interesting. So, you know how tough blood infections are, right? Sepsis, lots of money, wrong antibiotics, patients waiting for the bottles to culture. So this was a 4-hour answer. Here's what they did. They got together with the infectious disease docs. A resident came in to the lab twice a day when the test came off at like 11 a.m. and 4 p.m. And they had a resident call every referring doc to say, here's the results. So you have a highly accurate result now on what the bug is and which antibiotics you want to start. That's what caused mortality to drop 50, I think it was 51%, and the morbidity 74%. That's a big win, isn't it? So, a year later I was having lunch with somebody who was the director at Florida Hospital, which is 800-900 beds. And I was telling him this story, and he says, guess what? We were offering the same test. We couldn't get the doctors to do anything with it. So we don't offer it anymore. Now, there's a 50% reduction in mortality because of the lack of interaction between lab and clinical staff. That's your opportunity going forward if you want to be proactive. Okay, I want to say a word about the Affordable Care Act. Even Obama likes the name now, although I'm not sure he's happy with how it's going. First thing is, at all times, the government doesn't have any money. Okay? They're trying to bring 30 million more people in to insurance, and the money's not there. All these other things are going to be happening regardless of Obamacare. You know why? Because all Obamacare is addressing right now is health insurance. It's not telling doctors to practice differently. It's not paying doctors differently. It's simply changing the way the insurance system operates. So everything I've shared with you this morning is independent of the ACA and Obamacare. And how that works going forward, we can have another conversation on another day. Okay, in our little Q&A, we can talk a little bit about price transparency. Hospitals are not going to be able to get away with charge master prices anymore. Medical tourism is still out there. Being a patient-centric lab, your lab is going to need to know everything about the patient at the time the patient shows up for blood draw. Because amongst other things, you need to collect the money from them. I have an HSA. I pay the first $3,000 a year, 100%. Then my insurance kicks in. So if I show up January, February, March, June, September, you got to collect 100% from me. Sonora Quest has put in an enterprise-wide master patient index and actually has billing people in 1 out of every 5 patient service centers. And when the patient walks in, if they owe money or they're a cash-paying customer, they make their arrangements at the time of the blood draw to make that good. So patient-centric is important, and your LIS is only physician-centric. So you're going to have to layer some middleware on top of that. Health system consolidation. Anybody know about Theranos and Walgreens? Theranos is out there, founded by a woman 10 years ago who dropped out of Stanford as a junior. $100 million of venture capital. They have this little capillary stick collection device. They say they can do all the lab tests on that volume of specimen at Medicare prices. And Walgreens has agreed to set up and offer Theranos testing in 8,500 pharmacies around the country. The first one's in Palo Alto, where the Theranos CLIA lab is. Phoenix is the next place. So this is potentially disruptive, although no one knows much about Theranos. So you're in for challenging times. It's not lab medicine the way you've known it. It's quite a new world. Remember this, anytime there's change, people and labs that stay with the status quo are going to become irrelevant. People that see the change as a lab and adapt to the change have opportunities and can seize new opportunities for that. So, anybody know who this fella is? It's Warren Buffett. Okay? This is a great quote. In a chronically leaking boat, energy devoted to changing vessels is more productive than energy devoted to catching leaks. So that's one message for you all here in the halls of academia. Go forward. Now, you know who this fella is? This is very good. He's been out of hockey now for a decade or more. What was the famous quote? Wayne was asked, why do you score so many goals? And what did he say?
Skate to where the puck's going to be, not where it is.
Yeah, I always skate to where the puck will be, not to where it is. But I thought that this was an equally incisive quote. You miss 100% of the shots you never take. Okay, I'm going to close here and say thank you for being a very attentive audience. And I guess we have time for a few questions and Now, was this helpful for you? Sure. Just kind of sort through all the headlines you've been hearing and the health system initiatives? Yes?
I want to go back to your comments about primary care providers in Massachusetts. There is some evidence that we're going to be at least 50,000
primary care short.
We have a cap on training programs that was put in place in 1997. And so we are not able at the present time to take any more people into treating as residents. Do you have any idea how this is going to be solved?
Well, this is the contradiction of your federal government. Let's take money away from medical training just at the time that you're going to need more medical specialists of all types. By the way, on the airplane up, I had a Wall Street Journal, and the very last section is kind of their lifestyle section, and it was like 6 pictures of people, and it says, when you go to the doctor now, who are you going to talk to? I don't know if some of you saw that.
It was the team.
It was the team. And so there was the physician, the physician assistant, somebody who was like a customer service. It was very interesting. It's the medical homes model. And so now you're seeing it come out in the press that, hey, you're not going to go to the doctor and see Marcus Welby anymore. You're going to go to the doctor and you're going to interact with any of these 6 or 7 different kinds of functions. So that's a good question. We can always go recruit them overseas.
Yeah, but they've got to take training here if they're going to practice.
Yeah, but this is really interesting about nurses. The United Kingdom goes and recruits nurses from South Africa. Then South Africa goes to some place like Congo and Nigeria and recruits them. And there's a whole stream that the European countries are recruiting outside their nation. And then each successive country is going to recruit in the next pool. So you really have a global movement of skilled people, but at different skill levels. Yes?
So in the labs, we're really kind of held hostage by CPT coding.
Yes.
Individual tests, and it actually would be much better if the people in the know in the laboratories were able to put the algorithm together. The physician can't possibly know all of the different tests, what the pluses and minuses are, what the redundancy is between a particular PCR assay or array or whatever. So what do you see happening to CPT coding in the future?
So you all heard the question about CPT codes. It's kind of like limits you. If you're going to practice integrated medicine, then you're going to have to integrate the algorithms. And you're going to move away from CPT code as a fee-for-service reimbursement vehicle. Have you had Mike LaPosada up for a grand rounds in recent years?
Not recent.
So you all know who Mike LaPosada is?
Yeah.
You know, Mike's one of those fellas that at Vanderbilt now, he's been able to start developing the concept of the diagnostic management team, where the pathologist is embedded or the clinical chemist is embedded with the right specialist. And then they're developing these care algorithms that are very comprehensive. They want to order the right test at the right time, but they also want to measure how spending money on that test changed the cost of that episode of care. And that's where this is all going to go. So what do labs do well? They gather data. We were talking about this at dinner. I had a management mentor, really, really bright guy in my career. And one of the things he told me is, Robert, I shared this with Leo yesterday, if you don't know the numbers, they're always worse than you think they are. Okay? Labs are good at measuring. If you'll measure and show people, you'll change things. The other part, when I started at Procter & Gamble, they said, really there was 3 things sequentially. Robert, you have to have good information to make good decisions. Number 2, we pay you as a manager to make decisions. So if you don't make any decisions at all and sit on the status quo, that's not good enough. Third, we know you're smart enough that if you make a bad decision, you'll pull it back before it hurts. And the whole point was, you're hired as a bias for action, but use good information. And I found in my career that when you sit down with people and you have the numbers, even if they don't like what the numbers say, they can't deny it. And that's labs, you've got to get out of spending most of your time looking at your analytical processes and saying, oh, all those errors start upstream, and really start engaging with the clinicians. You know, the days of being a pathologist that sits in front of a microscope pushing glass for CPT code reimbursement, they're going to end. And the real action is going to be consulting with the clinicians. You know, that was one of the good things that, one of the good models that Mike LaPosada talked about. You know, he's into coagulation. He said, I work at Harvard Medical School, Mass General, smartest doctors in the world. But when it comes to coag, they got 60 to 80 tests that they're going to use in their practice a week. They don't know when to order the test. They're going to look up the normal range to try and figure out what it means. So how am I doing them a favor as a lab to have them just check off a box and then we just send them results? And that's when he developed a different approach where with the medical committee's approval, they created test recs that said rule out these diseases. Then he could do the reflexive testing. And in the days of electronic health records, all you clinical pathologists know, you can really get into some mischief now. Because you've got all this cumulative lab test data, the results just coming out, and you can go back in and look at that against the health record and really be interventional. So you've got some great opportunities. Yes?
Seems like one of the real secrets of La Posada's success is that he figured out a way to bill for that. He figured out a way to bill a professional fee for doing that interpretation in addition to the technical fee for running the laboratory test. And that seems to be kind of a recurring theme in your talk, is the importance of pushing information to the clinicians in a meaningful way. And my question to you is, how can we continue to ensure that we actually get reimbursed for pushing that information and interpreting it, rather than just adding an extra layer of work on, like your resident who goes in and physically phones in the results of every single PCR assay but doesn't get paid for it?
Well, they figured, they had budget for that. They figured it cost them like $200 a day to bring the resident in, and somehow that was built into the budget. That was part of the story we wrote. It just wasn't the lab offering a rapid test. It was the lab changing the clinical practices of the care team relative to results. But to go back to La Posada, she makes a good point. Mike did not create any new CPT codes. There's 2 CPT codes out there already for the telephone consult and for the written consult, originated by the referring physician. And so go back to 1995, 96 when Mike was first doing this. I asked him a question. Some of us remember the closed panel HMOs, full risk capitation. I said, Mike, you know, for COAG professional pathology consultations, what kind of revenue you're generating? He said, we're generating about $400,000 a year. He says, of course, we bill about 1.2, and that's all we collect. I said, why would an HMO that had not been paying for a COAG professional opinion in earlier years suddenly be willing to pay $100,000, $500,000 a year for this? He said, because the physicians go to the HMO medical director and say, I'm practicing better medicine more accurately with a clinical pathology consultation for these patients than without it. That, to me, was the big take-home. It was the clinicians that were going to the HMO saying, let's keep this going.
Actually, a good model for us is the PharmDs. You know, pharmacists have gone from compounding and dispensing medications to being totally integrated into
Yes.
ordering and dosing schedules and monitoring. It's just, you know, ask a lot of clinicians, I'm saying they rely on the PharmDs for that.
Yes.
And that's a change that's taken place over 10 or 15 years.
And by the way, in California, the pharmacists have just gotten a law passed in the last 6 months that allows them to do lab tests and interpretations for those tests that are associated with a therapeutic drug. So they're really into managing the scope of practice laws in their favor as the target changes over time. Other questions or comments? Because I know you've got a busy schedule going on. Well, thank you very much.